Good morning. Thanks for the opportunity to speak to you today. And I wish I could be there in person, but the time difference just did not allow that. So I'm recording this for you. I'm going to talk about super spreading events and how to minimize aerosol transmission. I'll talk about the Skagit Valley Chorale event that we analyzed in great detail. And then I'll also share a little bit about our musician study that we're working on here to provide guidance so that musicians and performers can keep themselves safe. This diagram comes from Hugo Lee's paper showing the different ways that airborne transmission occurs. And I'd like to draw your attention to the infectious person on the left that's in the red, generating aerosol containing virus. And there's a wide distribution of particle sizes. The ballistic droplets are probably greater than about 100 microns. And then the cloud of aerosol has subsequent particle sizes of varying degrees, and probably the particle size that carries the virus that we know of right now is about 0.2 microns and above. When you're very close to the infectious person, you're right in that cloud of aerosol and also in the ballistic droplet range. And so this is a really important key piece of transmission that we should all need to be aware of. And then the long range airborne route is when you're farther away, but the aerosol is still mixing throughout the room and the particles are still airborne and you can still inhale them and become ill. I'd like to just talk about three events because I think that they can inform some of our understanding of super spreading in Hong Kong. This case, analyzed by Adams et al., was the largest local cluster with 106 cases, and I'm drawing your attention to B, which is the diagram cluster on the left in this figure, showing the bars cluster. And it was traced back to multiple social exposures among a collection of bars in Hong Kong. The evidence suggests that this bar and band cluster originated among a few staff members and customers, and then it was spread to additional venues by the musicians. However, it's a little bit difficult for the epidemiologist to determine the actual chains of transmission because of the many bar cases. But the earliest reported exposure was on March 7 among two customers who later presented with the symptoms, and then among two staff members. And then of the 73 primary bar cases, there were 39 customers, 20 staff, and 14 musicians infected, while the 33 other infections were secondary, tertiary, quaternary. And I'm drawing attention to this spreading event because there were musicians involved in the transmission, and there's not many that are reported other than from singing. This single outbreak accounts for 10% of all cases in Hong Kong, regardless of the source. This event in super spreading in Japan was reported by the CDC and found that 22 people were likely to have started these 62 case clusters of 5 or more cases. And half of them were 20 to 39-year-olds, which I think is of key interest. And for 16 people, the research team couldn't figure out when transmission occurred, which is important because it showed that 41% of them didn't have any symptoms when they spread the virus. In fact, the super spreaders only one had a cough when they infected the others. And the clusters were in healthcare facilities, that was 30% of them, and other care facilities like nursing homes and restaurants and bars and workplaces, and then also music-related events such as a live music concert. So again, music is playing into this transmission, although it's not known whether it's from the musicians or from the attendees at the concert. And of also interest is the fact that if you look at this graph up on the top A, you'll see that across the whole outbreak, the percent of cases was about 60% for this particular cluster. And they were then, number of cases reported per cluster were 5 and greater, and that healthcare facilities was a large part of this cluster. And the final comment that I want to make was from this analysis by Goyal et al., a really interesting modeling study that showed that most transmissions, as we are realizing, are pre-symptomatic, and the most infected people do not transmit the virus to anybody, but a small percentage secondarily infect large numbers of people. These super spreading events with 10 or more cases of secondary infections occur when the infected person is really briefly shedding at a very high viral load, and then also has high concurrent number of exposed contacts. This person infected with SARS-CoV-2 exposes more people within equivalent physical contact networks than a person infected actually with influenza, according to this analysis. And that is likely due to the significant aerosolization of the virus. And so they then analyzed different policies that would reduce this idea of like a high spreading event happening. And what they found out, so let's take a look on the graph on the upper right, where we see that the secondary transmissions are quite high when you also have a lot of COVID-2 RNA in your saliva and in your respiratory system. So these are shedding quite high numbers of virus. And then what we see is that when the percent of super spreaders of all infected people on the left in the lower graph are high, then the percent reduction in exposed contact rate, meaning there's high occupancy, is also high. And if you can reduce the occupancy, then you also can reduce the percent of super spreaders of all infected people, and then your probability of having a super spreading event goes quite down. And just to draw your attention to this study that does show that there is very minimal transmission, but it can happen outdoors, where of all 318 outbreaks involving 3 or more people, they were all indoors. And there was one where a 27-year-old man had a conversation outdoors with an individual for a lengthy period of time in close contact and then did get symptoms. But otherwise, most transmission happens among family members or family relatives and at home or in transport. This article that we wrote on a collaboration of international scientists draws our attention to how we might be able to minimize the release of aerosol and the buildup of aerosol that contains virus indoors. And we focus on ventilation, portable air cleaners, and UV disinfection. And I will comment on all 3 of these approaches to modulating the concentration indoors. And starting with ventilation, just a few comments on what is the appropriate indoor air supply. In this analysis, building ventilation was shown to be as effective as public health interventions, but existing ventilation rates are too low to prevent or control airborne infectious diseases indoors, as we are finding out rapidly, and we would need to increase them possibly by even 10 times. So the analysis on the right shows that if there's an index case and their ventilation rates in buildings are low to 1 air changes per hour, the percentage of daily infectors just really rises quite quickly. However, we can modulate the ventilation by increasing the outdoor air supply so that our air change even goes up to 7 air changes per hour. The percentage of daily infectors is quite low and is spread out over time so that it doesn't overwhelm the healthcare system. Also, this interesting analysis showed that the effect of increasing ventilation rate would drop the attack rate to 0 if the air changes was up around 10 air changes per hour, which is obviously quite high. In this recent paper that just came out looking at what modulated acute respiratory infection cases in dorms, we find that the high ventilation dorm that has 6 liters per second per person has only 1 acute respiratory infection in the dorm out of 11 cases, compared to in the low ventilation dorm with 2 liters per second per person, that almost half of the residents in that hall have acute respiratory infections over the study period. And so from this study, we can conclude that ventilation's rate need to be at least 5 liters per second per person for acute respiratory infections. And then the literature review by Pavel Wawracki showed that the outdoor air supply rate should be maybe even 25 liters per second per person, because if it's lower than that, we do see sick building symptoms increase, short-term leave increase, and also decreased productivity. So somewhere between 5 and 6 liters per second per person and 25 liters per second per person is where we should probably be thinking for airborne infectious disease control. In this outbreak of tuberculosis in university buildings, what was shown was that the outbreak was happening in buildings that had 1.7 liters per second per person air supply, and that the carbon dioxide within these buildings had built up to at least 1,200 on average parts per million CO2 indoors. And after engineering the ventilation system to increase the outdoor air supply to 24 liters per second per person, the carbon dioxide levels averaged around 600, and the outbreak of tuberculosis came to a stop. So let's talk about outbreaks due to inadequate ventilation and through aerosol transmission of SARS-CoV-2. We analyzed the Skagit Valley Chorale rehearsal outbreak that happened here in Washington State in March. We looked at two different goals. One was to first estimate the average quanta emission rate, and then to explore how ventilation or changes in the duration of the event would alter the risk of infection. We know from studying of airborne infectious disease transmission that these are the major factors that influence how diseases are transmitted. How the virus is spread, or the bacteria, depending on the disease, is spread spatially through the indoor environment. What are the airflow patterns, and how is it being diluted with outdoor air ventilation? How does the virus or bacteria survive while it's airborne? Does it inactivate quickly? And it does depend on temperature and relative humidity. And then very important is the aerodynamic diameter, which controls where it's going to go in the indoor environment, and also where it's deposited in the respiratory tract. And then how infectious it is depends on the region of the respiratory tract that has the receptors to enable the infection to gain hold. And then how infectious is the virus, and what's your immune status of the host. And finally, the face coverings, germicidal, UV, filtration, and ventilation are additional control members that influence how the diseases are transmitted. And so if we go to the Wells-Riley model, it provides a quick assessment of infectious risk of airborne transmissible disease, and it's been used for this, since it was first developed and applied in the 1940s and 50s. And Dr. Wells defined this idea of quantum, which is a hypothetical infectious dose unit. And it was useful at the time because they didn't have all of the microbiological tools that we have today to try to assess viral activity and number of virions in an aerosol particle, for example. And so using this quantum idea, you can predict the probability of infection based on this quanta, and you use the Poisson probability distribution, assuming well-mixed air at steady state with discrete infectious particles being generated, and that the particle concentrations vary with ventilation rate. And the graph on the upper right shows the effect of ventilation on the probability of catching measles. This was an application of the Wells-Riley model by Riley et al. In the 1970s. And the study was undertaken in New York, where their elementary school outbreak happened because a second grader introduced measles, and it was spread to 60 other pupils over the course of a month. And so the scientists collected data on room ventilation rates, time spent in each room, and the amount of virus in the air. And then they used this model to predict how the probability that each student would capture the measles based on various factors. And what's interesting is just to really observe how quickly the probability of catching measles drops when the air changes per hour increases to above even 2 air changes per hour, because this is really driving the virus out of the indoor air and bringing in fresh air from outside. So in our application of the Wells-Riley model, we use the multi-hit exponential form, and it looks like this, where P is a 1 minus exponential function of n, the number of quanta inhaled. And we estimate the average quanta concentration in the rehearsal space by estimating the volume of air that was breathed and the duration of the vent and the breathing rate, as well as predicting n, because we know the probability of infection was 87%. And then we also couple this with a well-mixed material balance model to get the quanta concentration in the room, and it depends on the emission rate, the volume of the rehearsal space, and the loss rate that's going on within the space. And this encompasses ventilation, deposition onto surfaces, and virus decay. So some details of the outbreak. We collected these details in a questionnaire to the chorale members by talking in great detail with one of the representatives of the chorale, and also making phone calls and talking with the maintenance facilities people at the church and the installer of the furnace that was at the rehearsal space. 61 of 122 members attended this rehearsal on March 10, where we think the transmission occurred through aerosol emissions from an index patient. The precautions that were taken was hand sanitizer, no hugging and no handshakes, and chairs were distanced, but to around a meter. And we do know that there was an index case that had mild cold symptoms the day of the rehearsal. And the index case was seated in close proximity to only a small proportion of the other members. 50% of the chairs were unoccupied, and no one was located within 3 meters of the index case. We did see that during parts of the rehearsal when groups were moving between rooms, 2 members were within 1 meter to the side, 4 other members within 2 meters behind the index case. And then there was some talking in small groups of 3 to 4, but the index case conversed minimally during this 10-minute break. We also know that 50% of asymptomatic cases transmit the disease, but that only 20% really remain asymptomatic. And we estimate that the probability was low, that there were other transmitters because of the low community prevalence. We estimate the likelihood of an asymptomatic transmitter as around 0.32%. Symptoms set in for the members of the rehearsal from March 11 to 22. And among 61 attendees, we have 53 cases identified, 33 confirmed with PCR, and 20 unconfirmed, but testing was unavailable to many. These are the parameters that we used in our Monte Carlo simulation. We have the volumetric breathing rate. The loss rate due to ventilation was between 0.3 and 1 air changes per hour. The surface deposition based on the assumed particle sizes that were released and inactivation of the virus as it's airborne. And the duration of the rehearsal was 2.5 hours. So we put all this together in our modeling efforts. What we predicted is that this solid dark black line is the quanta emission rate, and the probability of infection at 87% and 1 air changes per hour is depicted here in this point. There is a range and uncertainty of the quanta emission rate due to the Monte Carlo simulation. And as we increase the ventilation rate and the surface deposition rates, we do see that the probability of infection decreases. And then if we get up to about 6 or even 8 air changes per hour, our probability of infection does drop to 20% from 87%. So we do see that ventilation is, actually it's closer to 30%, isn't it? We do see that ventilation does help reduce the risk of this high super spreading event from happening and transmitting to so many people. But it would be great to bring this rate of infection down even more in these risky situations. And so we changed the duration of the event from 2.5 hours with the solid black line down to 2 hours, 1 hour, and then even a half hour. And with a half hour, what we see is that even at that low ventilation rate and the probability of infection being 87% with 2.5 hour duration, if you're there for just a half hour, your probability of infection drops by only 10%. You're just not exposing yourself to a buildup of virus in the air. And just moving on to a few comments about filtration and germicidal UV to modulate super spreading events and keep the aerosol load low indoors. We have to make sure that if we're going to supplement ventilation with air cleaners, that we need to know how much clean air is being processed by the cleaner. And so we use something called the clean air delivery rate, which tells us both the efficiency of the filter and how much power the fan is pulling the air through the filter. And the Association of Home Appliance Manufacturers certifies air cleaners in the US to provide us the square feet for what space should be used in. And in a study that we did looking at a variety of bioaerosols, we showed that it really didn't matter what bioaerosol you were treating. If you were treating fungi with quite a large aerodynamic diameter of 5 microns or a smaller mycobacteria of about 1 micron, the clean air delivery rate for these two bioaerosols was statistically significantly similar for both Air Cleaner 1 and Air Cleaner 2. But Air Cleaner 2 had quite a much lower clean air delivery rate. And so what that means is Air Cleaner 1 with the higher clean air delivery rate can clean a 30 cubic meter room, but Air Cleaner 2 can only clean a 4 cubic meter room. Moving on briefly to germicidal ultraviolet light, we do know that 254, even up to 265 wavelengths can inactivate the DNA of airborne microbes. And the microbial response to germicidal UV has been documented for quite a variety of organisms. TB was where I worked for many years for reducing TB transmission, and its inactivation rate is shown here, and it's comparable to the data we have on coronaviruses. So we know that coronaviruses are susceptible to UV. A common application of UV is upper room air disinfection, and it's used in rooms in which infectious aerosol may be generated, or in rooms where you need to supplement the ventilation, or in crowded environments where unsuspected infectious persons may be present. In a day school in Philadelphia, Dr. Wells used germicidal UV to reduce measles transmission and did show that over the study period, the unirradiated classrooms had a higher susceptibility infection rate compared to irradiated classrooms. And we collected data over 3 years for the CDC guideline and showed that this was quite an effective technology, but that the room does need to be well mixed. If you provide warm air at the ceiling, you did cause stratification, and the effectiveness of the UV was significantly tiered and reduced. And these are the guidelines that CDC NIOSH provides for healthcare workers. And it's a really effective strategy to reduce airborne infectious disease transmission. It's been analyzed in some modeling studies by the National Institute of Standards and Technology, and showing that to really increase your air changes per hour to up around 25 at the high level of where we might want it for airborne infectious disease control, you would need to implement UV. And you could also add filtration, but UV is really the key here. And you can also put UV in an air duct, but you do need to make sure that there is enough airflow that is slow enough so that you do have a contact time with the virus. And then if you're going to use it, you need to put it in the mixed air supply where it's much more effective. And let me conclude with some comments on our music and performers aerosol study run by myself as the PI at CU Boulder, and also teaming up with the University of Maryland research team. In our chamber, we have been aerosolizing by singing and playing clarinets and other instruments, and sampling the aerosol plume right at the bell of the instrument, and also probing in other locations in the instrument, both around the mouth and at the keyholes. But these data are right from the bell, where you have the aerosol generation right going into the aerosol particle sizer, which measures between 0.5 and 10 microns particles. We see peaks of aerosol being generated when you're singing with no mask at close range, which we know causes superspreading events under the right conditions. Also, playing a clarinet at close range can get those aerosol particles to elevate, and singing with no mask again at close range. Whereas when we sing with no mask at 1 meter away from the sampling inlet, we see that the aerosol concentration is undetectable and in the background. As well as singing with mask at close range, really you see no sampled aerosol in the front of the person. These were using surgical masks. This is showing you the distribution of particle sizes from 0.5 micron up to 10 microns, and we do see all particle sizes. Oboe was the instrument that generated the highest concentration, 5 times higher aerosol concentrations compared to other instruments. And so we think that's because there's a lot of back pressure being generated when you play the aerosol, play the oboe, and then aerosol is formed. Singing, here is again the particle size distribution and concentration with singing, and with a mask it's reduced. And so this data is all normalized to the oboe concentration, so you can see relative to the highest oboe aerosol concentrations, the flute was quite low. And when you're doing your work performance with a mask, either with a slit for the inlet or for singing, you do reduce your aerosol release. And then with the bell cover, it brings it down to almost the background level. And in some modeling studies, we looked at how effective wearing a mask was, or also how effective the transmission would be indoors wearing a mask. And this was work done out of University of Maryland. And what we see is that without a mask on the left, the risk of transmission is quite low until you get to about an hour singing within 1 meter of the singer. But with a mask, it's also in a canopy tent, the plume behind the singer does not develop as far away from the singer. Indoors, without a mask, we see after 60 minutes that the aerosol concentration has sufficiently mixed within the room to cause the infection risk to be double what it was if you were only singing for 30 minutes. And with a mask, with 64% efficiency, the transmission area that's infectious remains very small around the source. And this again is assuming perfect fit. We cannot model that piece. And so in conclusion, I'd like to just emphasize that this result of generating aerosol for short periods of time, like 30 minutes, or being exposed for 30 minutes and then taking a break and going outside or stopping generating aerosol has also been shown in modeling studies by Arsene Melikov at DTU. And I'm just about out of time, so I want to conclude with a huge thanks to the University of Colorado, all of my wonderful collaborators over the years, my students, and the funding, especially from the NFHS and the cbDNA organizations. And this is just an example of a flyer that was put together by one of the schools following our guidelines from our study, reminding people that you must distance 6 feet or more with a mask, that outdoors you practice for 60-minute blocks with 6-foot spacing and some pauses, and indoors you must pause for 1 air change between each class and only do it for 30 minutes. And you need 2 layers or more of dense fabric for the mask and for the bell cover. And with that, I'll conclude. Thank you.